All right, welcome back. Another episode of Now I Know, episode 6. We're talking about the light adjustable lens. I'm Sam Barry, joined by Dr. Sud Koushik. Sud, let's
Hey
talk about
guys,
light adjustable
excited.
lens.
Yeah, I'm pumped. I mean, I think it's a great topic, great lens. What do you normally talk about with patients for the light adjustable lens? Anything different that you're doing in preoperative counseling to kind of set expectations and kind of guide that process for these patients?
Yeah, absolutely. I think we treat a lot of the cataract evaluations exactly the same in terms of our counseling and available lens options. And once we kind of narrow in on what a patient is hoping for post-operatively, then we start talking about what lens would best suit them. And then when we start talking about light adjustable lens, we have some additional information, both our own and from RxSight, the company that makes the light adjustable lens. Because I think there's a lot of education that needs to happen, a lot of understanding about how the process, especially post-operatively, is a bit different with light adjustable lens. Is yours somewhat similar in terms of kind of how you counsel a little bit differently on the light adjustable lens?
Yeah, I mean, I would say pretty much the same thing. It's more just expectations, kind of guiding them through what the journey will be like after surgery. I kind of explain it to patients where surgery is the same exact process. There's no real difference there in terms of us putting the lens in the eye, but your journey after surgery will require anywhere from like a 3 to 5 adjustments at the light delivery device. And then during that time period, also expect to wear UV protecting glasses, and so this can take even up to 8 to 10 weeks overall to get everything teed up for you. And I really like to make sure they understand how long it's going to take, just so that they're not surprised with that entire journey and that entire process.
Yeah, I say something very, very similar, and I love those glasses. I mean, you get 3 pairs of glasses, after surgery. They're cool UV blocking
Yeah.
glasses. I also tell folks, and this is off-label, so we're not endorsed by the company, we're not sponsored by the company, which is nice. So we can talk freely about it and just the way that, we use it in our experience. There's now active shield on the
Mhm.
lens, which means the front surface is kind of coated with this material that is kind of like a shield against ambient UV radiation. So I tell people not to stress out about wearing the sunglasses or the clear glasses inside. I don't know if you do something similar, but I say try your very best to wear them outside. Don't have a heart attack. Don't stress out if you forget it once or twice. Like, do your very best. But if you forget it once or twice, you don't need to call an emergency line to our clinic and let us know. It's going to be okay because of that active shield. Whereas earlier, before,
Yeah.
the active shield, it really was very UV sensitive in terms of the lens. Now, the way that we use the light delivery device, it takes down that active shield first and then does the treatment. But just backing up, we're kind of skipping ahead to our level of, other surgeons and talking about our own experience with them. Backing up to a very basic understanding for med students and residents, people that don't have experience with using the light adjustable lens. So we do cataract surgery in the very same normal way we normally do cataract surgery. And once we remove the cataract, and a little teaser here, we'll have a video a little later in the episode of actual, surgical implantation that we did a few weeks ago for the light adjustable lens. So on the YouTube, you'll be able to see that. On the podcast, you'll have Dr. Koushik narrating it. So either way is a win-win in terms of watching it versus listening. But we do cataract surgery the same exact as normal. And then we put the light adjustable lens into the capsular bag. And we can, again, talk about that as well because it is a 3-piece. So it could go in the sulcus. But again, just going back to the basics, we put the lens in just like any other lens. And then we're done with cataract surgery, just like any other cataract surgery. So the actual surgery is no different. The lens material is really no different than other lenses that we use. It's a silicone optic with PMMA haptics. So again, just the exact same in terms of patient experience, patient expectations. Afterwards, outcomes in terms of vision is very similar to any other monofocal lens, but the advantage of the light adjustable lens is that adjustability. So we can use a machine to make changes to the power of the lens while it's still inside the eye without any further surgeries and with very minimal manipulation. I tell people it's like sitting at, a slit lamp or putting your chin in our normal exam lane and just sitting there for about 1.5 to 2 minutes. Is that similar to what you kind of tell people to expect for the actual light delivery device procedure?
Yeah, exactly. It's a very smooth process. I do say that it's like sitting in the slit lamp. And in terms of the amount of time that it takes for us to do that adjustment, I say it kind of varies, but you can expect anywhere between maybe like 30 seconds to 2 minutes in that
Hmm.
range, just depending on what stage of the treatment we're going through. But yeah, it's a very easy, smooth process. And we're done very quickly.
Yeah. So what's remarkable about this lens, I mean, I love talking about this lens with patients because it feels like we're living in the future. Like it feels like something that, and
Mhm.
I remember learning about this lens in development when I was in medical school. So I remember in medical school hearing about it. It was in development. I think actually the company is based in California where you're in practice, Dr. Koushik. I remember them
Yeah.
developing the lens there. Yeah. And they were talking about how they can adjust it with a UV light while it's still inside the eye of the patient post-operatively. And I was like skeptical. I was like, I think this will probably never come to market. No way this can work. I mean, this is remarkable. How could this be a real technology? And now I've been in practice for a couple years doing this light adjustable lens. So it's made it to market. It's had great outcomes. And it's something that I choose very frequently for my patients. So really, really cool. Feels like we're living in the future. I tell patients that all the time.
Yeah, I mean, it's amazing technology and the ability to go ahead and change this prescription after surgery without taking the patient to the OR, without doing any kind of incisions or anything of that nature, I think is just spectacular. Actually, talking about this with patients, are there certain types of patients that you're choosing to use this technology on? Is it kind of open for pretty much anyone to utilize? I guess what does the layperson need to know in terms of are they a good candidate for?
I'd say just a quick answer is yes, everybody's a candidate. I think everybody really is a candidate
Mhm.
for the light adjustable lens. There's very few reasons that there are what are called contraindications or reasons somebody should not get the light adjustable lens. But there's certain FDA approvals as well, which are pretty broad. But even outside of that, I've used it off label for patients that, maybe don't meet the FDA requirements, but I think it's still good medical practice to implant it for them if that's their goal. If that's still in their best interest, we can still, like many things in ophthalmology, do off label use as long as it's, in their best interest. So how about you, Dr. Koshik? Are there certain things that you look for? I know in the FDA trial and the FDA approval, there's certain things that, in terms of light sensitizing medications that patients can be on, things
Yeah.
like Soralens or doxycycline, chloroquine. These are all ones
Mhm.
that are relative contraindications, I'd say. So I do screen patients for being on certain
Yeah.
medications, but at the same time, if we can get off the medications for a bit or, just monitor for any phototoxicity while we do the treatments and after, I think I haven't seen personally any true retinal toxicity from the UV light, and that's extremely rare for that to happen.
Yeah, I agree. I haven't seen anything like that in the patients that we've implanted this lens. But kind of going back to your question about things that we're looking for, even in the preoperative exam, definitely looking for good dilation in these patients. I think RX site recommends having the patients dilated pupil at least be 7 millimeters in diameter. I know that lens optic is 6 millimeters, so you just want to make sure you're able to actually capture that entire optic when you are able to do the light delivery device treatments. So that's one thing is pupillary dilation. And then, yeah, to your point about medications and those kind of relative contraindications, I have not had any issues with that. I know they also talk about patients who have a history of any sort of maybe like herpes uveitis or keratitis and those kind of issues. I'm trying to think back and see if I had any patients with that, and I don't believe I have. But I think even that's a scenario in which you could have a discussion with the patient and do kind of like a prophylactic um, treatment of medication leading up to their cataract surgery and even after cataract surgery to kind of minimize that risk. So those are kind of things that they mention as relative contraindications and that you can take into account and appropriately counsel and also treat before doing surgery.
Yeah, I completely agree. Completely agree. I mean, are there any patients that you've had that, wanted light adjustable lens and you felt like weren't a candidate for it? I can't think of anybody in particular.
I also think talking about patients that may be good candidates or may not be good candidates. I think I've heard different ranges for how much astigmatism can actually be adequately
Hmm.
treated by the LAL. And so I believe RX site says up to 2 diopters, but I think talking to other surgeons, we see that you're able to treat a little bit more because you can do multiple treatments. So I think we've seen in our hands maybe about 3 diopters, up to 3, I guess I would say, that can actually be successfully treated. Any thoughts on that?
Yeah, I was just going to bring up that point, and I'm glad you beat me to it. I mean, the one, I'd say not contraindication, but the thing that I think about on preoperative testing is if somebody has a lot of cylinder, they may be better suited by a toric lens, or a toric multifocal, or something else that with toric lenses, those are the astigmatism correcting lenses that have, built-in cylinder correction. They can go up higher, right? They can go like 4, 5, 5.5, almost 6 diopters of cylindrical correction, which is certainly more than we can do with light adjustable lens. So if somebody is very high in terms of the cylinder, I say maybe the light adjustable lens is not the best lens for you, but we have other great options. So there are really good options still for those patients, and just correcting that amount of cyl is huge. So I don't feel like they're missing out very much on that light adjustable lens technology, because their outcome is going to be so impressive anyway. So it's not like in my mind, it's not like a true loss of anything, because they're benefiting so much from that 4 or 5 or more diopters of cylinder correction.
Yeah, definitely. And that makes perfect sense. Like we've talked about in previous episodes, just really debulking that astigmatism is so paramount. So if they would be a better candidate for a different lens due to the amount of astigmatism they have, then by all means, I think we should go ahead and do that. In terms of for utilizing LAL in patients who are coming in wanting, I guess, more independence from their glasses, like not just setting them for distance vision in both eyes. Do you find like there's a big advantage there to help patients achieve monovision, achieve a little more spectacle independence by utilizing LAL technology?
Yeah, you bring up a great point. I think that's one of the reasons that the light adjustable lens is so indispensable in our practice, is it allows that test driving of vision post-operatively with patients. So they can determine how much distance vision they want, how much near vision. And the way we can do that is either through the lens itself or through contact lens trials, and then adjusting the lens based on those trials. So not to delve too deep into the weeds, but from a patient perspective, the ability to test drive the vision post-operatively is such a huge advantage. And then be able to tell your surgeon and your doctor, hey, this is what I'm looking for. I want a little bit more near vision. And, we typically do that in the non-dominant eye. And so we kind of go over the pros and cons of, adjusting for near means losing a little bit of distance vision, depending on how much near vision you want. So we kind of go through all these things with the patient, trial it in the phoropter, so trial it in the exam room, do a contact lens trial if we're not sure. So I think it's great for spectacle independence. It requires a bit more post-operative chair time is what we say. So more time coming to clinic, and more time, test driving the vision, making the adjustments, test driving again until we finally lock it in. Now, once it's locked in, it's stable. You don't have to keep coming in. The lens doesn't keep changing. That's the way that you want your vision to be. So we lock it in, meaning we just set the lens that way. So that's what I tell patients is once we reach that happy, once they're 20 happy, we lock in the lens.
Yeah, and Sam, I just want to jump in here because I think this topic is something that quickly becomes like the art of communication with patients, and something I'll just speak on my own behalf when I mention locking into patients. I do have some patients that I think get a little bit apprehensive with, okay, you're locking it in, it's done. There's a very much a feeling of it's a finality to it. We're done and we can't go back and change things. And I kind of like to tell patients, well, we've had all these treatments and we've gotten you to this point where you're happy and now we're locking it in. If we never use this lens or this technology and we used a standard monofocal lens, you're essentially locked in right off the bat the moment we're done, with the surgery in the OR. So I think that helps lower a little bit of apprehension on the patient side where they kind of get a better understanding of, okay, we've gone through this journey together. I'm happy, and that's why we're quote unquote locking it in. But I don't know if that's like a thing that you've experienced with your patients, but it is something that I have, and so I tried to frame it in a more positive light.
I'm just smiling because I do the exact same thing. We've never talked about this, but it's so funny that we reached the same exact point, in talking with patients, which is there is that, definitely, you're so right, that apprehension of locking in and being like, wow, this is now final. We're not going to keep adjusting the lens. So there's apprehension on the patient side, and on our side, we want patients to be as thrilled as they can be with their vision, and we want to keep adjusting it as much as we can until they're perfectly happy. I do the same thing. I'm like, we've been seeing each other and we've been making these adjustments, and we wouldn't have that opportunity if we had the monofocal lens only, right? So I say the exact same thing, which this opportunity this kind of apprehension of locking it in is kind of a blessing of the light adjustable lens, that we've been able to make all these adjustments. But I was just laughing to myself because I was like, I do the same exact thing. We all have that apprehensive patient, and one day I'll be that apprehensive patient, because, skipping ahead to what I wanted to talk about later is, if I was having cataract surgery tomorrow, I would have the light adjustable lens. That's what I tell people, because that's what I would choose right now.
Yeah.
August 2024, that's what I would choose, is light adjustable lens, for all those reasons, because very detail oriented. I want that ability to make the small changes post-operatively, get as much glasses independence as I possibly can, mostly for distance. But if I want to adjust for up close, if I want a little bit of mono or blended vision, we can experiment with that and do that as well. So that's what I would do right now.
Yeah. No, I mean, I agree with you. I think that is probably the best option for myself at the current point as well. Talking about near vision, talking about mono, I wanted to pick your brain a little bit, and I'll tell you what I do, and I'd love to hear what you do in terms of setting a patient for their near eye. Let's say they're going for maybe a minus 1.5 in their near eye. How do you best utilize LAL to get you there? Are you trying to just hit that minus 1.5 off the bat right when you put the lens in the eye? That way you have less work on the back end when you're doing treatments and then finally locking it in, or are you actually maybe a little bit less myopic to start off, and then you're working a little more myopic with your light treatments? And I'll tell you, at least from what I've been doing, if a patient is, let's say, aiming for a minus 150, oftentimes I'll probably think about putting them at about a minus one, see if they like that post-operatively, and then I can always shift in a myopic direction with the treatment and kind of get that enhanced depth of focus through that treatment, versus aiming for minus 150. And then if I went too myopic, now I have to kind of start working in the other direction, which I feel like doesn't help the patient as much and doesn't benefit the patient as much. So I don't know what your thoughts are with that whole monovision near your target, all of that.
I do the exact same thing as you, just like before. I mean, it's
Oh.
funny that again, this is the first time we're talking about this. We do the exact same things. And I think it's nice to have two people with experience, two surgeons with experience independently, and then reaching the same conclusion. I think that speaks to, at least to me, that's a great way of doing it, that we both found success doing it that way. So next topic. I do exactly what you do. No, I'm just kidding. I think there's also backing up
We'll keep
for a
that
moment.
brief. Yeah.
Yeah. Backing up for a moment, we could talk about this for hours, because there's so many topics within light adjustable lens, but even choosing which eye we're adjusting. So backing it up to basics, you can ask a patient, which is your dominant eye? I don't know what you do in California, but in Missouri, we say, what's your shooting eye? And people generally know what their shooting eye is. I don't know if there's any corollary. Is there anything in the Bay Area about ocular dominance?
Oh man, that's a great question. I don't know. Maybe what eye do you like to look through the viewfinder of your camera for when you're
That's a good
doing
one.
nature photography or shooting the Bay Bridge? I don't have a great one for that, but I like the what's your shooting eye. And having been in Missouri myself with you, I use that quite frequently.
Yeah. So in terms of doing it in clinic, do you have a preference of doing it a certain way? I know what we do in clinic is I have patients when I'm there, because I really want to make sure I'm double checking this. Even if our technicians check it, I still double check it. I just want this to be nailed down, that this is their dominant eye and this is their non-dominant eye. So I have patients hold up their arms in the clinic lane and make kind of a small rectangle or square within their hands. And I put a letter up on the chart and I ask them to center it up with both eyes open. And then either I ask them to close one, or sometimes I'll occlude one just with my hand. So I'll just cover up one of their eyes and say, can you still see that letter? Or did it move? Is it, not centered anymore? Is that similar, or do you do it a different way for ocular dominance?
No, I pretty much do the exact same thing. I usually have them make like a small triangle or diamond shape, pyramid shape. And then I have found, at least just for ease, I tell them, just hold your head still, hold your eyes still, you don't move. And then I'll go ahead and occlude for them, because I find it just to be a lot faster and a little more efficient if I go ahead and occlude their eye. And then that way they are not having to think about head position, eye position, which eye is closing or anything like that. But I do the exact same thing as you. And so I think that works out really well. And I agree to your point. Definitely make sure you're rechecking it as the surgeon, even though someone else has done it and they probably did a fantastic job. You just want that peace of mind for yourself and for the patient. So I always recheck.
Yep. Yep. I remember as a medical student and as like a first year resident, just feeling like a total idiot. Like, I don't know how to check ocular dominance. How could I not know something so basic? But it's kind of tricky. It does require some patient cooperation.
Yeah.
There's ways that are more objective of checking it with kind of like cover testing or alternate cover testing of in terms of seeing where they're fixating and seeing those small motions of the eye. But I really find it best when it's cooperative with the patient. Is that kind of similar to what you found?
Yeah, definitely. Yeah. And then one thing we didn't mention is just also make sure the patient does have their best corrected, spectacles or whatever on their face so that they're actually able to focus on that target at distance.
That's a great point. Yeah. You got to make sure I have them like kind of read a couple letters on whatever line we're
Yeah.
doing, whether that's 2020 or 2040 or whatever. And then I put up one letter. And that one letter, I have them center
Mhm.
up in that little triangle in their hands. And then, like you said, occlude each eye. And, if they tell you it moved, great. If they move their head, then I know that they're trying to find that again. Yeah. Especially
Mhm.
important to get this nailed down for light adjustable lens. Important for other lenses too, but especially for light adjustable
Yeah.
lens, I find.
Yeah, totally agree. And then even with, I think we can get a little more nuanced here. I don't know how detailed we want to get between the light adjustable lens and then the light adjustable lens plus or the LAL plus,
Mm-hmm.
because that lens is out and it also does. I think it is marketed as an ability to get a little more intermediate and near with that lens without really sacrificing too much of distance vision. I myself have not implanted LAL plus. I have seen some patients with LAL plus uh, post-operatively, but any thoughts as to how you're positioning that for these patients who are having monovision? Are you putting LAL in the dominant eye and LAL plus in the near eye, or would you consider doing something like that, or would you put LAL plus in both eyes and then just still aim for kind of a mono in their near eye?
Yeah, I like that idea. I like the idea a lot of LAL plus, maybe in the non-dominant eye, LAL for the distance eye if we're talking about mono or blended vision. But again, personally myself, I haven't
Mhm.
put in any LAL plus. A little bit early, just in terms of being released, how many, like a couple months, 2 months, 3 months ago now. So relatively new to
Yeah,
the
yeah.
market. The light adjustable lens has been around for many years now, like 4, 5, 6
Mhm.
years. So I had a good amount of experience with that. As far as I can tell and reading the DFU for the LAL and for LAL plus, there shouldn't be much difference in our experience and in the patient's experience. So I wouldn't have, for people listening, for patients listening, and for us, I wouldn't like stress about it too much. I wouldn't put too much emphasis on it. I
Mhm.
think either way is going to be a great outcome. They're not worlds of difference. You were talking about what you aim for with monovision, with the near eye, if it's like -1 or 150 or 175, and how we kind of go a little bit stepwise through that. There's also backing up a step. There's what are you aiming for preoperatively? And for me, I almost
Mhm.
always, I can't think of a case where I didn't aim for distance for both eyes. I honestly aim for distance, even hitting that first plus, usually, like up to plus a quarter or so.
Mhm.
And that way I know we're adjusting myopically. And we have found that adjusting myopically can increase that extended depth of focus, that range of near vision. So
Yeah.
I think there's a benefit to doing that. Even if you know you're going to end up, shooting myopic as a target, I think adjusting myopically versus going straight for like a -1 or 150. Is that similar to what you do?
Yeah, no, I once again totally agree, and it sounds like we're just in cahoots at this point, but we haven't rehearsed these things. This is all on the fly. So yeah, I totally agree. Going in a myopic direction is so advantageous, and so that I would rather do that in any scenario than have to go the other way. So aiming plano or even like a first plus, and then kind of working your way into a myopic direction, I think works really well. And then that way you're not, you're helping the patient gain this. Depth of focus. So I think that's very beneficial.
Yep. I totally agree. And going back to your point in terms of going kind of stepwise towards that myopic goal, I think that's great.
Mhm.
Going to a -1, that's typically what I shoot for first. Either -0.75, -3/4 of a diopter, or -1 is where I shoot
Mhm.
for that non-dominant eye while we're adjusting the dominant eye for plano distance. And we can do that
Mhm.
also with a contact lens in the meantime. So we can talk about timing for a second
Yeah.
here. That kind of segues well, which is
Yeah.
I see them at either same day or next day for a post-op visit. And then typically most cataract surgery patients we see at a week, again, just to see how they're healing, how things are going. Typically, I do that with light adjustable lens cataract surgery patients as well. Not always, but at that 1 week visit, we have the opportunity to potentially trial a contact lens, like a +1 or a +150. And during that time, I have them wear that and then come back a week or two later for the first light adjustments. And at that point, they can tell me kind of what they experienced and whether they wore it, or whether they liked that contact lens in near vision, or whether they didn't. So it's really nice for people who have never tried Monovision. It's hard to try Monovision before surgery because you have a cataract typically. And so the quality of vision is thrown off anyway. So post-operatively being able to do that and then adjust it is a huge advantage to patients. So I don't know if you do something similar, or if you just, some patients, they know they want Monovision. So we just make the adjustment in the lens to about a -75 or -1, knowing we could reverse it if we needed to.
Yeah, no, I think that's a great point. I think for patients who have had prior refractive surgery and they've already had monovision through, let's say, LASIK in the past, and they know they like it, they know they enjoy that near vision in their non-dominant eye, I kind of will just plan for that. I don't really need to sit with them to kind of do a contact lens approach or trial with it. But if they are new to this whole process, then yeah, I think that's a great approach, having the contact lens, having them try that out and kind of take it stepwise like you outlined. The other thing about the timeline I think it's important to mention just for listeners is after that, typically, at least for me, you do the 4-month or 4-week recovery period after cataract surgery, and then we won't do any sort of treatments or adjustments until after that 1 month. And then the spacing in between treatments, I'll just make this point too, is ideally we want to get where we only have to offer one treatment for the patient and then we go ahead and lock it in. That's like the ideal case scenario. Every now and then, obviously, you will have to do a second treatment or possibly even a third treatment. But the spacing between treatments, I like to wait anywhere from like 5 to 7 days between the spacing of treatments or lock-ins. I know you can theoretically go a little bit shorter with that. And so I think that will also depend a lot on how the patient's doing, if they're battling any other kind of things like dry eye, stuff like that we need to address. Will affect the spacing of the treatments. But anything differently that you do for that, for the overall, when you do the treatments and when you do the lock-ins and things of that nature?
Yeah, we finally found some differences. Finally, it's been a while. We've been doing exactly the same things. But I'd say honestly, 99% of the time I do it exactly like you say, like exactly like that. Now, I do have some people that we have done their first eye and their second eye in terms of cataract surgery and LAL. Their second eye is a week or two later. And so from that second eye, sometimes we only wait that minimum period. Sometimes we do the adjustments at 2 weeks or so, 2.5 weeks after that second eye. If things seem super stable, if we're making small adjustments, not anything drastic. So I will do it at that minimum. I think is it 17 days? We do about 2.5 weeks for the earliest treatment we would possibly do. But I'd say typically it's closer to 4 weeks after surgery. And I try to do both eyes for light adjustable lenses, especially. And this is a whole nother topic, but I try to do both eyes close together, like a day or two, tops 1 week apart. But if I can do, same day or next day for light adjustable lens, that way both eyes are healing at the same time. Our adjustments can be made right around the same time. I find that very advantageous.
Yeah, that makes sense. We definitely need to, if we can incorporate essentially even immediately sequential bilateral surgery and have LAL in both the right and left eye on the same day, that would be ideal.
Yep. That's a teaser for a future episode. I really hope we can get Dr. Nathan Haseman on the pod to talk about ISBCS, or immediately sequential bilateral cataract surgery, which, this is me being biased, but I hope it's going to start to take off soon. It's a hot topic within the ophthalmology community, and there's certainly patients that are good candidates and patients that we wouldn't even offer it for. So there's a whole spectrum, but I think a lot of patients could potentially benefit, and I think a lot of surgeons are comfortable offering it for the right patients. So again, just a little teaser there, a little bit of a nugget for a future episode, but I love being able to do same day or next day cataract surgery for these patients.
Yeah, definitely. It just makes it so much easier for the patient, easier for the surgeon. And then even in terms of what you want to think about in terms of overall societal impact financially and with time and things like that and resources, I think it makes a lot of sense.
There's so many points.
Definitely will have to address that.
Yeah, there's so many good points when it comes to so many benefits and win-wins from ISBCS, from same-day bilateral cataract surgery. So we'll have to talk for hours about that. Might have to split that into multiple episodes, because
Yeah.
I was also thinking about
Yeah,
other
it ought to
things.
sink in.
Yeah, we've learned so much from our mentors, and Dr. Hazeman being one of them. That brought up another point of biometry, preoperative biometry, and what we look
Mhm.
for. And when we talk about biometry, we talk about, as a patient, you're going through all these machines and you're not sure what's what. But one of the machines you always go through before cataract surgery is what's called optical biometry, which is where we use a light source and a bunch of sensors in order to measure both the curvature of the cornea, the front of the eye, as well as the length of the eye and some other parameters kind of within the eye. But again, that's something we learned so much from Dr. Hazeman in terms of how to interpret biometry, especially in post-refractive patients. So all these things, we could do a whole episode on looking at optical biometry, whether that's the IOL Master, LensStar, Pentacam XL. There's lots of optical biometers out there now, and we could I think it'd be fun to go through screenshots of each one, go through
Yeah.
what they're measuring, go through what we're looking at, what we prioritize, and then any red flags that we're looking out for, especially with post-refractive, post-LASIK, post-PRK, post-RK patients.
Yeah, definitely. I think there's a wealth of information there that we need to sort through, and that'll be a great future podcast episode.
Yeah. Just a quick one for our med student and resident level. When we're looking at a biometry of somebody that's had, let's say, myopic LASIK, we should, in our heads, if we know that history, in our heads, we should think about how will that change the corneal curvature, and then interpret the biometry based on that, looking at the K values, looking at the steepness of the cornea, just at a very basic level. If somebody's had LASIK or PRK, they should not have much astigmatism at this point, right? Because we've eliminated that, hopefully, with that laser refractive procedure. So another reason the light adjustable lens is especially well suited to these patients is, number one, they typically have low astigmatism. Number two is our formulas, and we could talk all about formulas after we talk about biometry, but our formulas take in certain parameters from those measurements of that patient's eye, and based on those parameters, they calculate a lens power. Basically, it gives us a number, a power of the lens to put in based on those measurements, and refractive surgery changes it. So it's less precise after you've had LASIK or PRK. And so that's the reason that I especially find light adjustable lens beneficial, is if we're missing the mark more in those patients, being able to adjust post-operatively is a huge, huge advantage to them and to us, right? Because let's talk about if we didn't have that. So rewind to when Dr. Koushik was 10 or 15 years old, only 5 or 6 years ago, not long ago. And this lens wasn't on the market. Light adjustable lens wasn't on the market. At that point, the only way that we could address that residual refractive error, which means missing the mark with our calculations for the power of the lens with cataract surgery, the only way we could do that is, number one, glasses, number two, contacts, and then number three is further surgery. And further surgery can mean either, LASIK again, PRK again, or for the first time, or exchanging that lens for a different power of lens. So those are all much more, I think we'd agree, much more invasive and much less precise, honestly, ways of addressing that residual refractive error. So if we're talking about a post-LASIK patient, myself included, we're some of the more kind of demanding, detail-oriented patients that there are. And so we want to be nailing that, hitting that mark every time. And so it's just a real bummer that it decreases our ability to hit that mark by changing the cornea in ways that are not predictable to our formulas. Is that a good recap of kind of what we're thinking about, and what our lens calculations and power and adjustability, how that all kind of factors into cataract surgery?
Yeah, definitely. I think that's a great recap. And then another, I think, quick little pearl for the resident level, or even medical student level. When you are seeing these printouts that the biometer are displaying, you'll see at the top, usually they'll have the axial length of the eye, they'll have the average K of the eye. And since most patients typically have a myopic LASIK, if they've had refractive surgery in the past, more myopic corrections, just quickly take a look at those Ks and see if they are reduced. And you can use an average of like maybe 44 to 45. And if you're seeing something like 40 or in severe, cases coming down to even like 38 or something like that. Those should be like red flags in your head. Like, let me really figure out what's going on here, ask the patient a lot of questions, because a lot of the times, at least in my experience, and it might be similar in your experience, Sam, is you'll ask a patient, have you ever had any sort of eye surgery, any eye procedure in the past? And they'll tell you, nope, I never had anything done. And then you'll look at the slit lamp and you can clearly see a LASIK flap. And I've had many patients straight up tell me, oh, I didn't realize that would count as an eye surgery. But yes, I did have LASIK. I'm always like, no, yeah, that was definitely a procedure. That was a surgery. So
I'm
I
laughing
think,
because I could see myself doing that. I could see myself, if
yeah,
somebody asked me, hey, have you had eye
yeah,
surgery before? I'd be like, eye surgery? No, definitely not. They're like, what about when you were
yeah,
22 and you had LASIK? I'm like, yeah, that was just like a morning. It took an hour. I was in and out, that doesn't count,
yep,
but it does matter to us. It does. But it's funny because I can see myself being that
exactly.
patient.
Oh, of course. I
So,
mean, I think we do at this day and age, we do such a good job of the experience is so fast and efficient and painless and the recovery so quick that, it's very easy for patients to kind of forget about it and be like, yeah, this is my vision. It's always been like this. But yes, to residents and medical students, when you're looking at those biometers, really take a look at, I mean, you should look at everything. Obviously, I'm not glossing over that, but if you do take a look at the average Ks, that'll tell you a lot within a second of, okay, maybe this person has had refractive surgery in the past and I need to explore this further.
yep, that's a great point. And I also try to talk about that with our technicians that are doing the measurements for that optical
Mhm.
biometry. For our clinic, that means the IOL master. So our technicians that are doing the IOL
Mhm.
master, I love when they're like super interested in it. And, sometimes it sends up red flags as just part of its algorithm. It says this is unusual, like a high axial length, or it's not getting accurate keratometry measurements, things like that. But on top of that, if they're just interested in learning about the biometry, I love talking with them. I'll talk their ear off about it, They probably want to leave at some point, but I'm like, no, let's talk more about biometry. And I tell them, think about an
You,
average eye. Think about like, you know, let's say 23 millimeters maybe as an average eye. And then also the K is, like you said, 44 diopters. The units don't matter so much. Just think about the typical numbers that you're looking for. So if somebody has a very, very high
Mhm.
axial length, they should be nearsighted. And if they're, you kind of have to factor in those two things. You have to factor in both the Ks, the keratometry, and the axial length. But if you think of those two variables
Mhm.
and you have a high axial length and normal Ks, you should be myopic. You should be nearsighted. Or if you have very, very high Ks or keratometry and a normal axial length, again, nearsighted. And the reverse is true, right? If you have very, very flat Ks and normal axial length, hyperopic or farsighted. So this is something that you can just do really quickly, mental math in your head based on those
Mhm.
average numbers of what kind of an emmetropic or a plano regular eye would be. And that's something I love for our technicians to do and have on their minds for multiple reasons. I mean, number one, like you said, LASIK and PRK picking up on it. Number two, if they see those super flat Ks and they haven't had LASIK or PRK, maybe they have a contact lens in, right? Maybe they're wearing a
Mhm.
contact lens while they're doing the biometry, even though they ask about it. Maybe the
Mhm.
patient forgot or something happened, but it's important to pick up on those things because we base our lens power on that, and it's very important. That's like ultimately the Bible for us as surgeons is that optical biometry.
Definitely. And it's funny because as you're mentioning this, I don't know why my head's going to an image of you cornering a tech in the side of the office and just like talk to them about biometry. And they're like, Dr. Barry, please, I need to get home.
Yep. Yeah, that may have happened. Our IOL master kind of sits in a corner of the exam lane.
Yeah.
And so, when they're looking at the machine,
Mhm.
I'm like, let's talk about this for hours. And they're like, I just want to go to lunch. I'm like, we could talk about this a little bit more, though. We could learn, we could learn more about the IOL master and
We can keep
biometry.
going. Yeah.
Yeah. All
Yeah.
right. Well, going back to light adjustable lens, because I know you're, we're both a
Yeah.
little pressed for time this morning, but can I share my screen and look at from a patient perspective
Oh,
and from a
yeah.
surgeon
Yeah.
perspective what the LAL looks like as a lens being inserted at the end
Mhm.
of cataract surgery? Let's see. Share screen. All right. How's that looking?
Got it. Yep. I'm seeing it.
Got
I'm
it.
going to make it
All
expand.
right. I know there's
Yeah.
maybe a little delay because we're doing this remotely, but I'll kind of narrate it as we go too. So the light adjustable lens is a 3-piece lens, and it goes through that clear corneal wound just like every other cataract surgery lens. It has its own kind of implantation injector. but very easy to learn, as a surgeon, how to inject that lens. And I inject it, whether it's into the capsular bag or into the AC, into the sulcus, but then I take the IA probe and just irrigation on, inflate the bag, and make sure the optic and both haptics are within the capsular bag. And then I just remove the viscoelastic, and that's it. So, I mean, it's just like every other cataract surgery lens. From a patient perspective, no difference. You can't tell the difference at all from the surgery. From a surgeon perspective, it's just like any other IOL that we're using. You have to, do training and learn how to inject it and feel comfortable with it before you do it with a patient. And RxSight, to their credit, does a very, very good job of having their representatives come out and make sure you're fully comfortable and happy before you inject this for a patient. The last thing you want is to be doing something makes you feel uncomfortable, or that's unusual for your cataract patients. So I'll just back up here again and show that implantation one more time. But they do such a good job. I'm sure, Dr. Koushik, you had training on injecting it. I had training on injecting it. The first couple of cases can be, a little bit different than what you're used to if you're used to all, acrylic monofocal lenses. But it's a very simple, straightforward adjustment, and I don't think twice about it now. How about yourself?
Yeah, I totally agree, and I mean, I think it is a testament to how great the reps are from RxSight. But yeah, they coach you through it. You get to practice on kind of simulated cases before you do it on a real patient, and then even for your first few cases with real patients, they're obviously there to walk you through, have any kind of questions that they can help answer. But yeah, it's a slightly different technique, I think, when you're first using it, especially when you're used to acrylic lenses. But really, it's not that much different, especially if you're a resident and you've done a three-piece lens, like an AR40 in the sulcus or something like that. I mean, you have a lot of the same foundation right there in terms of how your hand position, how the lens is going to kind of go into the eye, and how you're going to have to adjust as the lens is coming out. So I think if you've done a three-piece IOL before, that only helps you in terms of getting adjusted to the LA.
Yeah, I couldn't agree more. And that's a separate topic that I'm kind of passionate about. But as residents and fellows, as surgeons, we got to be able to do every step of the procedure ourselves. Like if somebody in the operating room doesn't know how to do what's typically their part, let's say the scrub tech doesn't know how to set up the machine or load the lens, you got to be able to do every part. And I sound like a broken record and kind of like a crotchety old man when I say that, but I really believe it. You want to feel, it makes you feel more comfortable in the OR to know I could set up this whole table. I could set up the operating, scope. I could set up the machine. I could do every single step that is needed for this patient. And other people are there to help me a lot of the time, and they do such a good job. But if push comes to shove and it has to happen, then I can do every step. There's no technology I don't understand. There's no lens I couldn't load. And going to resident level, taking the time to load how to learn three-piece lenses is really important, because the time when you need three-piece lenses, besides the lead adjustable lens, but the time when you need three-piece lenses is when you have surgical complications generally, right? So you don't want to be stressed about a PCR, a complication of cataract surgery that we can manage well. Yeah, if you do a good job, you manage it well, the patient has a great outcome. But if you're uncomfortable and you don't know what you're doing with loading a lens, it can just add to the stress. So going into it to know I can load this lens, I know how to inject it, I know every part of this, it really brings that stress level down, and you can get that patient a great outcome.
Yeah, and I'll say this kind of random anecdote, but since Sam and I both trained at University of Missouri, and we did work at the Harry S. Truman VA, which is a fantastic facility with amazing faculty. But I think it was President Truman who had like a plaque on his desk that said "The buck stops here." And so, I mean, to your point about the surgeon needing to know every single step, needing to know how to set up everything and adjust to any sort of scenario that could arise, I totally agree. I mean, the buck stops with you as the surgeon. So you need to have kind of full responsibility and full understanding of every single component in that OR and how it works, so that you can jump in if needed for any step. Yeah.
Yep. And it's such a good time for like a wet lab. It's a great time with your co-residents and other folks that get the reps to come in from those companies to teach you how to load the lens. They're fantastic at it. I know all of our local reps in St. Louis and Columbia, that whole area. I mean, they're fantastic about coming in and training not just us as surgeons, but also our technicians. and making sure everyone's comfortable with loading the lens that we choose as surgeons and as patients. So I remember fondly, doing some 3-piece lenses again with Dr. Hazeman, just a great mentor. But the Bosch and Lomb Li6 1AO, I remember making a video as a first-year resident about how to auto inject that lens, because it has its own kind of way of loading it as a 3-piece lens. So just really fun. And if technologically now all these kids, with their little smartphone devices, it's way better if you are taking the time to do this, just record it too. And that way you can watch it back yourself, make yourself a little reminder video. Part of the benefit I've found of making surgical videos is not just helping educate other people, but having it as like an encyclopedia for myself, and saying like, when this came up last time, even if it's a very rare thing, how did I do it? It not only helps us as game film to improve our surgery case after case, but also to document rare things and, kind of have an encyclopedia that we can reference going back. And so I find that super beneficial to myself. And luckily, it's also beneficial to other people that want to watch those videos. I did that not too long ago for the Lioli injector, for the Evo ICL, because I was learning how to do that. And I found it super helpful to make a video for myself. And then other people have told me, man, I watched that video because I don't do too many Evo, in their practice. But they're like, when I need to do it, I love being able to watch that video, and it makes me very comfortable because I've seen it and I've done it, but I don't do it as frequently, maybe as it's not muscle memory yet for them. I would tell them to just do enough Evo where it becomes muscle memory, but that's a separate video. I love Evo enough to be doing it very frequently. Yeah. So, yeah.
It's a definite remedy to any solution. Just do it a bunch of times and you'll be fine. Yeah.
That's true.
Just do it a lot. Yeah.
Yeah. Well, great episode. We probably have even more topics to talk about when it comes to light adjustable lens. I mean, we do have many more topics in terms of kind of the post-operative period. We could talk more about how to adjust, when to adjust, even more in depth. We didn't even touch much on RK, radial keratotomy, and how those patients are great for multiple lenses, light adjustable lens being one, I'd say Apthera another. All these are just great topics for future episodes. Anything else on this episode, Dr. Koushik, that you wanted to bring up about LAL or LAL Plus or 3-piece lenses? All these topics have been great.
No, I think we hit the highlights. Definitely, there's so many nuances that we can go into, especially with patients like who have had RK or even keratoconus and things like that. So we can definitely delve into that in future episodes. But I think we hit a lot of the highlights.
Awesome. Episode 6 is a wrap then. Episode 6, now I know light adjustable lens. Thanks for tuning in.
Thank you, guys.